welcome. Thank you. My name is Sue, and you are here, and I'm welcoming you to the session that is our supportive care and symptoms management partner for your journey, and excited to have you here in person today. I have the honor of introducing Dr. Kimberly Cassine. Dr. Cassine is the Director of Supportive and Palliative Care Outpatient Services for Emory Healthcare, and serves as the Director and Primary Provider for the Supportive Oncology Clinic at Winship Cancer Institute. She is board certified in internal medicine, geriatrics, and palliative care. She is part of the clinical care team providing physical, emotional, and spiritual care for patients with cancer at any point in their disease process and assisting patients with complex decisions. Dr. Cassine completed her medical school training at Virginia Commonwealth University in 2000. She completed internal medicine residency training at Yale University and completed fellowship training in geriatrics and palliative care at the University of Arkansas for Medical Sciences. Dr. Cassine has also been named one of the Palliative Medicine Inspirational Leaders Under 40 by the American Cancer of Hospice and Palliative Medicine for 2014 and 15. And she has been consistently listed in Atlanta Magazine's annual Top Donors since 2020. So we are lucky to have Dr. Cassine with us. And besides all the wonderful work she does, and she's going to talk about, she's lived here in Atlanta for 10 years, and she keeps busy with her 7-year-old son, 2 dogs, and lots of other family around, especially around the holidays. So please welcome Dr. Kimberly Cassine.
Thank you. Good morning. It's a real honor to be here, and I'm incredibly grateful because if I was not here, I would be cleaning bathrooms at home. So I will stay as long as you would like me to. Okay. So I just want to know how many people in the room have heard of supportive care. How about palliative care? Yes. Great. Have you had any experiences or met any palliative care providers or had any experiences personally with palliative care? Okay, great. All right. So I'd like this to be interactive. I would like to get through my slides, but the slides aren't as important as answering all of your questions today. So anytime you want to stop, please go ahead, and the slides will be available to you. I have no relevant disclosures, unfortunately. So when we think and we talk about, I see patients with cancer with all kinds of, serious illnesses. But one thing they have in common when you have a serious illness is the idea of resilience and strength. Right? Everything is framed from that standpoint. So if you are going to we talk about fighting for your journey, how you move through the world, you have to be positive, have to be strong. And that's a lot of pressure to put on someone. Does it ever get difficult to feel resilient and strong? Yeah. And when we think about kind of what makes up resilience, you have to be able to take care of yourself, you have to be able to actively solve problems, you have to have meaning and purpose, great social support, and maintain a positive outlook, all at the same time. So, that seems to me like a lot of work. I have a lot of patients that come in and often say, I used to be so strong. I'm sorry that I'm tearful. I failed this treatment, right? And so in order to have resilience, and the way we define it here, you have to have a sense of self. And resilience is actually defined as something that takes a blow, but is then able to come back exactly as it was. I think that for people who have cancer or who've suffered a trauma, I'm not sure it's good to be resilient. And what I mean by that is that if you have a life-changing event, you can come back, but you're not going to come back quite like the way you did before. So the expectation of, in addition to doing everything that you're already doing, then to maintain a sense of normalcy when things aren't normal is not particularly fair. So when we think about palliative care, why do we exist? Well, we are the medical specialty that specializes in the medical care for people living with serious illness. It focuses on providing relief of symptoms. The goal is to improve the quality of life for both the patient and the family and the caregiver. It's provided by a team and other specialists who work together with other patients' doctors to provide an extra layer of support. And it's appropriate at any age and any stage of the illness. And it can be provided with curative treatment. So when you look at that definition, what's missing there? What's not there? Right. Resilience isn't there. And dying isn't there. Okay. So when we think about palliative care and supportive care, it's exactly what we're saying. That no matter where a person is in that journey, whether they're going to start that journey, whether they're in the middle of that journey, whether they're coming to the end of that journey, whether they ended that journey and about to start a new one, it doesn't negate the need for support. So I sort of think about, your cancer teams as being this bridge, and it's really strong, and you have all these things coming at you. Who we are in this scenario, if I can work the pointer, we're just a support under the bridge. And I like to also think of ourselves as the mortar in between the rocks. Because how many times when you're going through your journey do things just sort of slip through the cracks? Right? You ever submit a form, like for FMLA, and the form doesn't come back? Or you have a question that maybe is not necessarily oncology, and your primary is not quite sure, and that kind of leaves you, but it's really important to you. It's really important to you at the time, but it's not really falling in any of the buckets. Well, that's when things start going through the cracks. That makes that bridge unstable, and that makes it really hard for you to fall. So we are just that support, and we're the mortar through the cracks. So when people ask me, what are you going to do when you come to visit, I'd say what happens in the visit depends on what you need at the time. So when you think about the scope, I like to use lots of pictures, but I think this is probably a more active description of where we are. So if you get diagnosed with a serious illness, and you start having those symptoms, we start thinking about, when you first get diagnosed, how are we going to make this work? And then, as we figured out how we're going to make it work, then we start thinking about how you're going to live with us. And I don't want to shy away, because everybody's journey is different. And as we all will, one day we'll decline from something. And then we think about how we are going to make sure people live the best life for as long as they can. And how do we support them when they go on to their next journey. And we do this, and we think about it in this way, is because what does serious illness threaten? It threatens certainty, it threatens your security, confidence, stability, and well-being. Is that fair? Yeah. And unfortunately, there's not always a pill for these things because they're incredibly complex. But in order to do the things that we're asking you to do, treatment, clinical trials, stay healthy. You know, there's a whole thing. You look at your appointments and they're like 45,000 appointments. In order to do those things, it's really important that we have some of these intact. And if we can't keep things intact, we have to also figure out how are you going to live with these things. Does that make sense? Yeah. And we have to be okay knowing that, you know, and often see that the way people react to illness and the way they move through their journey is really based on what they feel most threatened by. So what are we offering if your medical provider refers you to palliative care? Right. So we're helping, the 3 H's, we help achieve what the goals are and assist people with what they need. So when you come to a palliative care or you come to supportive care, what are we going to focus on, what the agenda is really what you set. And whatever that goal is, whether we agree or not, that's the goal and that's what we're striving for. Hoping. We help you explore, you know, hope. We help reframe hope as clinical conditions change, when it gets really, really hard, and holistic. So we focus on the whole person, and what I mean by that is, when you go to your oncology appointment, what are we focused on? Rightfully so. If I go to my oncology appointment, I want to talk about, you know, what's the next steps, how is it going to work, you know, all the logistics of that. However, you're more than that. And so if you go into that appointment and your pain's not controlled, and you're terribly depressed, and you're incredibly stressed, and, you know, not to even mention the financial toxicity these illnesses cause, it's really, really hard to sort of focus maybe on what your doctor's saying. It colors things. So just as important as your cancer, all of these other things are important and they need time. But the way our healthcare system is set up, your oncology team may not always be allowed the time. I think they would if they could, but these appointments are like 15 minutes, 30 minutes. But all of this needs a lot of attention. So our philosophy, we are willing to let you seek the goals, we become your partners, and we work through all that uncertainty together. So why do we operate in the medical system? Again, when it's not certain, we often operate where medical evidence fails, right? There's not a clear answer, there's not a clear protocol, and we meet you where you are. So ASCO, do you, have you ever experienced a time where it seems like all the oncologists leave? Like, there's a certain time when they all go to ASCO, which is their huge conference. And ASCO has put out these guidelines and said that supportive care should be available to maximize quality of life for patients through all phases of illness. It's not equivalent to hospice care, and hospice is a vehicle that delivers palliative care when a person's at the end of life. When you hear the term supportive oncology, sometimes people think of supportive oncology as only palliative care, but the truth is, there's only a part that I can do. And as you're moving through your journey, you may need other things. So we help, but when you think about cancer rehabilitation, financial advocacy, integrative medicine, nutritional counseling, psychiatry, social work, we fall as all part of what's going to help support you through your journey. And sometimes I find that when patients come to us, they've been struggling with a problem and they never realized that all of these things were available to them. And fortunately, being in Atlanta, many of the healthcare systems have these things. They call them different things, but they have them. And so when you're struggling with a problem, and you're saying, gosh, that's probably not really what my oncology team is going to do, maybe I'll just kind of muddle through it, I'm encouraging you to speak up, because there's probably some place in supportive oncology that is there to help you. I talk a little bit about hospice because sometimes when people come to us or they refuse, they're worried that we're hospice. And so I spend time explaining that palliative care is the umbrella, and hospice is just the palliative care people receive at the end of life. It's an insurance benefit. It's the way that we have figured out how to support the medical needs when we have illnesses that cannot be cured and people need a lot more physical support. So where can you get it? So you can get primary palliative care. So how many of your oncology teams have treated pain or treated nausea, right? Have they ever, when you've been upset, stopped and allowed you to cry or allowed you to be emotional? Yeah. So what they're doing in that moment is that they're delivering primary palliative care. And they're doing a fine job of it. Where blood cancers are different than solid tumors is that blood cancers tend to have really, really tight teams that do this very, very well. However, when the needs are going to outpace what they're able to provide, they may send you to somebody like me in an outpatient clinic, freestanding. If you're in the hospital, maybe pre-transplant, post-transplant, they may have somebody come in from palliative care to manage the pain, to manage the symptoms. And then we have home-based services as well, where people are not able to get back and forth. They can only get back and forth to treatment, but we deliver it in private homes. So what can be offered in the visit? So often people worry about, well, what are you going to talk about? Again, I'm going to talk about what you're hoping for. But primarily, we're often talking initially about symptoms because you feel terrible, so we need to start with that. We define goals. We figure out if you need community resources. We listen. So I say it's like palliative care appointment is like Vegas. Whatever you say, whatever happens there, happens there. We don't write it in the chart, but we allow you to sort of say things out loud that may be difficult to say to your medical teams, practice a little bit, things that might be difficult to share with family members. There's counseling, assistance with complex decision-making, and people always think about complex decision-making about end of life. A lot of complex decision-making we're having is about, if I get sick, who is going to be able to take off work to take care of me? Should I access disability? What are I going to tell my children? So there's a whole lot more. Again, caregiver support, making sure caregivers have resources, and of course we do advanced care planning. So patients and clinicians decide what the visit priorities are together, but you get to decide what the boundaries are. So when you come to a visit, we're going to talk about what you want to talk about. We're going to ask permission before we talk about things that we think might be sensitive. But you tell us what the boundary is, or you set the agenda. All right. Whew. So now we're going to run through some symptoms. So how many people have experienced fatigue? Yes, fatigue is the hardest. People think about pain, we're always talking about pain, but it's the fatigue that will drive people crazy, because in cancer-related fatigue, it's happening, it's an illness in and of itself. It's actually triggered by you having cancer, it's triggered by your treatment, but once this starts, it's off to the races. And I call it like the fatigue of ignition. So patients say, I'm so tired, and their family members are like, if you could just push through, and And I try to frame it like this. You are so tired that it doesn't even make sense to you. It's like you're looking at your shoes and you cannot figure out how you can get from the bed to your shoes. It seems impossible. Now, once you get to your shoes, you can do the activity. You don't have as much stamina, but you can get through that activity. So it's like a car that won't turn over. So anybody had a car that won't turn over, and so what you did was you run, and you push the car, and you jump in, and you drive? That's it. That's cancer-related fatigue. Like, I just can't turn it over. So cancer-related fatigue happens, I love studies that say it's between 25 and 99%. That means absolutely nothing. That's where we get all sciencey. But most people will experience fatigue through their therapy. It tends to improve after, the first year of treatment completion. So that means that if you're having ongoing treatment, you're going to be struggling with this. But it can last up to 5 years post-treatment, right? The hard part about this, because I don't know about you guys, if you've completed treatment and you've rung your bell, and doesn't everybody say how good you look? Everything's fine. You look so good. And then they just get back into life and go on life as normal, and then you can't do the things you used to do, and they're looking at you like, They go from being sympathetic to a little judgy. Do you ever feel a little judgy? Yeah. Because you look good, she looks amazing, but she's tired. And it's not like you can sleep it off. If you just got more rest and ate better, you would feel less tired. No, that's not how it works. It's not relieved with adequate sleep or rest. Counterintuitive, it's actually relieved with activity, which actually sounds insane to most people. Right, so the one thing that works, the one thing that always works is exercise. The problem is, if you hurt everywhere and you're having a really hard time and you can't, this puts you at a disadvantage. So when we think about non-pharmacologic treatments or things that you can do, because most people come to me with lots of symptoms and they say, Dr. Christine, I'm not taking any pills. Don't give me any pills. I'm like, okay, I won't give you pills. So if you don't want to do pills, then these are the things that have medical evidence to assist with cancer-related fatigue, including mindfulness. So that sounds weird, right? Because the fatigue is not in your mind, but there are things that you can do with your mind that can help you manage this. And there are things that you can do with your life. So I often tell patients, your mind and your body, you guys have a contract, right? It's a relationship. But every once in a while, your mind and your body, they don't agree. So if you all get into a fight, guess who's going to win every time? Body, right? Body's going to win. Now it might let your mind win. You might stay out at dinner and have a good time, but the next day, you're going to pay for it. Your body's like going to put you down. So I said, you can keep fighting that fight with your body. Your body's always going to win. Or you can say, body, I'm going to go out to dinner tonight. And then I'm going to choose next day to be pajama day. And I'm going to rest. Right. Versus thinking about what this is taking from you, trying to be normal. Accepting doesn't mean giving up. Accepting is working with what you have, the body that you have now, the person that you are now. So that's what some of the web-based programs and all of those things are. And acupuncture has medical evidence, cognitive behavioral therapy, and Tai Chi. So what about medications for fatigue? Because we love a pill, right? People want to come into the office and say, I am tired, and leave wakeful. So we thought it was a good idea to give people Ritalin and modafinil and stimulants, In 2024, ASCO brought together lots of experts, did extensive literature reviews, and the one thing they said, which is common practice, is they don't recommend us offering medications for fatigue. So generally I agree, because medications have side effects. For people who are able to move around and can do the exercise and have access, because a lot of those things over there I just showed you require money, right? Yes, yeah, sure, you can go get acupuncture for, $180 a session, including all of your copays. When that's not possible, sometimes we will still use medications on a PRN basis just to help you get through something. Right? But what ASCO is asking us not to do is to put you on something forever and always, because stimulants can be habit forming, and they do have other side effects. So if you can start with the non-pharm first, then this is the last resort. How many people are having trouble sleeping? Yes. How many people say, well, you just need better sleep hygiene? Did you turn the TV off when you went to bed? Do you just want to let go? So impaired sleep, common. The other things that happen, and I talk to patients, when I talk to them about sleep, just like everything else, if you have an illness, don't we try to get at the root of the illness as what's causing it? So when we think about sleep, we need to often think about why you're not sleeping. So your body is really smart. If you are in pain and you just go to sleep because you just can't stay up anymore, and you turn over on something that's painful, your body's going to wake you up, rightfully so. If you're not breathing well at night, and maybe you stop, your body's going to wake you up, rightfully so. So when you think about approaching sleep or you go to your doctor, sort of think about what's going on. I can't sleep. What is actually waking me up? Is it because I'm going to the bathroom a lot? Is it because my feet are burning? Is it because I feel kind of short of breath? If you can think of something maybe organic, am I worried? Am I anxious? What is the underlying issue? That helps us respond better to what will help for sleep. So these are the things that we should be assessing. So I tell you this because I think if patients are empowered, because physicians and advanced practice providers, we're amazing, but we can't think of everything. So the more that you sort of understand all the things that could be interfering, down to even some of the medications that we're giving you, that will help turn the light on and help us figure out what we can do. But you really shouldn't watch TV while you're in bed. That's bad. I have to say that, or they take away my doctor privilege. Okay. For insomnia, again, everybody wants a pill, right? Because everybody wants a pill. It's easier. But the first line treatment is cognitive behavioral therapy. And actually, the VA has a great app for that called CBTI. It's completely free, and the veterans use it. So I'm like, if the veterans are willing to do this, then we should probably give it a try. But it helps. The reason why we say this first is because it changes the behavior around sleep. A pill doesn't change the behavior around sleep. And then if you don't have the pill, after a while, the pill doesn't even make you sleepy anymore. But your body will withdraw from the pill. So now you're like on forever Ambien, doesn't halfway even make you sleep. And what your body's actually doing when it stops making you sleepy is it sees the pill and it triggers something in your mind to know that you should sleep. So I always try to convince people, I may give you a sleep aid, but if we don't do this, if we don't change our patterns around sleeping, this will always plague you. And again, I won't bore you with sleep hygiene because I know, but I have to nag you guys about that. Anybody have dry mouth? Oh, I'm sorry. Does anybody not have dry mouth? Why is your mouth dry? Because every medicine that we gave you dried your mouth. So what does that mean? So what are the symptoms of that? Particularly alter taste. When your mouth is really dry, it alters your taste. So in addition to the medications that we're giving you altering your taste, in addition to the cancer that is altering your taste, the dry mouth is also altering your taste. It may interfere with your ability to chew, and people who have to wear dentures, that gets really, really hard. It also interferes with your ability to swallow. So I don't know if you ever felt like, gosh, I can't swallow, and you're thinking, oh my goodness, do I have something else wrong with me? And then you go and you have a swallowing test, and the doctor says, no, you can swallow just fine, everything's fine. I don't know why you can't swallow. You don't have a neurologic condition, it's just dryness. Tooth decay. Anybody experience some dental issues? Yeah, we kind of left that out when we started the journey. We didn't that's our surprise. We don't talk enough about making sure you have good oral hygiene, that you don't leave your dentist right away, that you keep your mouth moist, because even after treatment, sometimes years after, that's when it starts, and that can be really devastating. And in addition to, it makes a nice environment for thrush. So what are the medications that will, and I'm sorry this wasn't a great background, but what are the medications that contribute to dry mouth? Pain medications like opioids, anti-inflammatory and your steroids, if you're on fluid pills, if you get radiation, any antidepressants, antihistamines, proton pump inhibitors. So yeah, and these are a lot of the medications that you may be on for symptom management. So now that I've depressed you about all the medications you have to take, what can we do about it? Well, want to be hydrated. So tricks are, if you're eating, sip of water, eat, sip of water, eat. Mucosal lubricants and saliva substitutes. That doesn't sound attractive, right? Yes, here's some artificial spit. I don't even know, when I say that to people, I'm like, oh my gosh. Best one, and I have no stock in this company, Xylamelts. Xylamelts. Not the spray, but it's a little melt. Doesn't taste too bad. You put it in your mouth, it lasts a long time. Great to keep it nice and moist during the night. This is where you break out your humidifiers, sugar-free candy. So you get to eat candy if your mouth is dry, yes. So when you're sitting there in infusion, you can just, yeah, Dr. Christine said, I can have this. And things that help you produce spit. The things that help you produce spit have other side effects. So that's probably going to be the last thing on the list, because they often interfere with other medications. But again, eating when you're out and you want to really enjoy it and you don't want to make a big deal out of it, sip, eat, sip, eat. Make sure you order something a little watery. Like, go ahead and get the soup, get the thing of fruit, and then you eat your steak and then a little bit of that, and that makes it so that you're not like hype, and then you push it away and everybody gets upset. How about mucositis? Anybody have mouth sores? Yeah. So why I bring this up and why I want to show this to you is that oftentimes I won't see somebody until they're here, grade 3. Because that's when we can start to visually see it with our eyes. But it starts before that with just that burning, just that sensitivity. So when you feel that sensitivity at that moment, that's when you raise your hand, an infusion or your oncology appointment or with somebody like me, that we need to start treating that now. That's when we get together, the magic mouthwash, which CVS will no longer mix and tell you to buy the things off your shelf, and which is really rough. Or you go to a compounding pharmacy and they want to charge you $1,000 for it. Oral rinses. So for some mucositises, oral rinses that they will give you, a little bit of biotin, things you can get over the counter. If it's really bad, if it's grade 4 and you can't swallow, you have to take pain medication. Likely opioid medication. Tylenol, ibuprofen, the rinses are not going to help. If it's bad enough to be in the hospital, you're likely going to get opioid pain medication. Sometimes patients have avoided this the whole time, but if you don't eat and drink, it's a spiral to nowhere. Again, artificial saliva, cryotherapy. So Have anybody heard of cold capping to keep your hair? Yeah. So what do your treatments do? They're getting rid of fast-growing cells. So the cells in your mouth turn over really quickly. So I'll have people say, okay, when they you start your infusion, get a ice pop or eat ice. Yeah, ice lollies. Mm-hmm. That's why somebody's in there chewing on ice. You're like, why are they chewing? It's freezing in here. Why are they eating ice? Again, it's the same thing around, it's the same sense around like cold capping. Really, really helpful. Doesn't get rid of all the mouth sores, and some things are just going to be here. Your diet can help trying to think of things that are not going to burn, and making sure people are making foods that are not particularly acidic. But again, when you see grade 1, you are going to know it. We can't see it. So you have to tell us. When we get to grade 4, you need some pain medication, okay? Sometimes they'll even say something crazy like take some liquid morphine, swish it around and spit it out. That's a thing because you have peripheral receptors. So how about pain? I like to start off with something called total pain. So the definition of pain is actually the damage to the tissue and what you sense, but it's also potential damage based on your perception. So has anybody ever said, well, that shouldn't be painful? Like, really? Is that helpful? No, because pain, what you feel, like you're not insane. If you feel pain, you're actually having pain. What the issue is, it's where the pain is actually coming from. So when you are having pain, it causes a vicious cycle for some people. It decreases your activity, it makes things worse, and that it's like gears turning. At the same time, when you have been in pain for a really long time, that can lead to anger and fear, sadness, depression, and when that's happening, it increases the perception of the pain. So sometimes I'll explain to people that when I ask you about your emotional state, I'm not saying you don't have pain, but it's like gears turning. If I cut here, that's going to keep turning. You're going to keep having pain. If I only treat your depression and anxiety, the physical thing is going to keep turning. So we have to be able to treat both. Does that make sense? Right, because they end up being completely intertwined. I want to talk a little bit about opioids. So we're in an opioid crisis, right? And before, way back in the day, if you had pain, we were terrible. We didn't treat pain very well. And then we had a revolution and realized, oh my goodness, all of these cancer patients, all of these patients have been suffering in pain and we haven't been treating it. So then we got on the opioid train and our goal was to make pain zero. And then something happened because we were using these medications, but we didn't fully understand the medications. So as people are living longer and longer, now we're starting to see the unintended consequences. The hard part is that these medications do have a place, but the way our society has chosen to treat them is more criminalized. So now, not only are people dealing with pain, now they're dealing with the shame of taking the medication for the pain. That's completely unfair. When these medications are really great for acute pain for short periods of time, now we know when they have to be on them for longer periods of time, they have the potential to alter the brain, change pain perception. That change in pain perception makes things hurt that normally wouldn't hurt. And then it becomes the medications driving the pain. Not all opioids do that, but the ones we use most commonly. So that's called something called central sensitization. So you start off with pain right here, and you're taking a medicine, and it's helping. And then after a while, it's as good as it's going to be. It has helped all it can. But you still have pain, so I give you a little more, and then you start getting worse. And so we're not sure. We increase it, we add other things, but the pain doesn't seem to get better. But now the pain starts to spread to other places that were never affected. That's what we mean by central sensitization. So that's what we need to watch out for. The other thing that we don't talk about if somebody has to be on opiates for a longer period of time is the increase of cardiovascular death, which is about equal to non-steroidal anti-inflammatories. If you have to be on it forever and always. We all know about the constipation, the nausea and vomiting. We don't fully understand immunosuppression, but particularly the endocrine for a lot of our younger patients. It can reduce muscle mass, testosterone, which interferes with intimacy, increases the risk of metabolic syndrome, which is high cholesterol, glucose intolerance, cause estrogen deficiency and osteoporosis over life. So I say that to say that when the doctors are coming in and they are nervous about giving you these meds, instead of us saying that this is what could happen, we just say no, or we become really frightened. The hard part is that when you are having acute pain, this is what we have. And in short term, this is not going to happen. If you have to be on these medications for long term, then we need to understand what the risk factors are and monitor for those risk factors. Because there are going to be some people who will need to take these medications in perpetuity to function. That is not their fault, but they have side effects like everything else. But if you do not have to be on them in perpetuity and you can get off of them when things are fairly stable, then let us try. Does that make sense? Is that fair? Right. But yeah, making people feel badly about it is not great. So a lot of doctors will now try to flip you to something called buprenorphine. And when we think about buprenorphine, it's the medication that's in Suboxone, and people associate that with opioid misuse disorder and addicts. Well, now we're using this medication primarily for pain. Because what we learned was buprenorphine controls pain. It doesn't, however, have the cardiovascular side effects. Doesn't seem to mess with your endocrine system. So this seems like a medication, if you have chronic pain, you can be on in perpetuity. So that's the push for using this medication. The hard part about it is, like with every other medication, it has side effects. It's still an opiate. If you stop it, you can still withdraw. And just like we talked about your oral care, if you have to take it orally, it's very hard on your teeth. Right? So if your doctor recommends this, it's not because they think you did anything wrong, but they're worried that you may need to have this type of pain control ongoing. And so they're going to try this, and if it's effective, good. If it's not, because it doesn't work for everyone, then we know we started with the safest thing, and if the safest thing isn't working, then maybe the risk of the next thing is acceptable. Does that make sense? All right, so we already talked about some of the side effects. So when we're thinking about treating pain and we say, okay, we want you to treat it emotionally, we want to treat your emotional pain. Few therapies can help that are evidence-based, right? So most people say, well, Kim, I don't want to, a lot of my patients call me Kim. Listen, Kim, I don't want to go and talk about my feelings and dig around in my past. How's that going to help my pain? I'm like, you know what, it's not. Because most people know the why. What you need to know about is what to do about it. So when you're willing to go to therapy, these are the three that have the evidence behind them. Cognitive behavioral therapy is therapy that helps you try to know what to do when you're experiencing this symptom. It's actually a process. It gives you something to do. How do you get out of the anxiety? How do you manage the pain crisis? Acceptance and commitment therapy is the type of therapy that helps you sort of accept that this is the body that you have now. This is actually happening. Because a lot of people get stuck in, not only am I having pain, but it needs to be normal. It needs to be normal. I need to be the way I was. Why am I not strong enough? And they spiral out, and the self-esteem just starts going down because they thought they were a stronger person, and they feel really, really weak because they're giving in. Acceptance and commitment therapy teaches you not to think that way. So you are able to help yourself and helps you reframe your personhood. Cognitive processing therapy and post-traumatic stress disorder. What do you think? Do you think it's reasonable if you were living your life and you had plans and then all of a sudden you walk in one day, you get this diagnosis, and your whole life changes? All your family life changes? Sometimes because of this, your financial life changes. And you are faced with your mortality in a way, because we all know we're going to die. But when you have a serious illness, it's like put in your face. You understand it in a different way than people who don't have serious illness. It is like there. Is that traumatic, maybe? Have you ever had an experience with maybe one of the doctors? And we're amazing, but sometimes we talk crazy. Like we just say something that we do, man. We mean well. Like there's a lot of goodness inside, but there is not a medical school course that said please don't communicate well. Like it's now medical school, they're teaching them now, but nobody taught us how to do that. We had to learn that. But sometimes we might say something very blunt. And you wake up in the middle of the night or you're cooking dinner and all of a sudden that thought just hits you and you're right back where you were before. Does that sound about right? What you have is PTSD. And if we don't think about that and don't treat it like that, the other two therapies really aren't for that. So if we recognize PTSD, then cognitive processing therapy and exposure therapy is just different. So that's the reason why it's really, really important, because if we don't deal with what's going on with you emotionally and mentally, even if you get past your illness, you will always live there, right? Because it will keep you there. Does that make sense? Because what happens is you get through your treatment, but what we don't tell you is that's the first mountain. Because treatment can only give you an opportunity for life. That's all it has. It does not tell you or guarantee you what that life is going to be like. So now, our part is over, and you're left with the pieces of your life that you have to put back together. And that's the next mountain. All in a body that you don't recognize and then you don't trust anymore because it already betrayed you. With the possibility that this could come back, and either in this form or another form. That's a lot to have to live with. So to ask you all to psychologically do that by yourselves is not entirely fair. So going on to some complementary therapies. So these are some complementary therapies that have some evidence behind them. Why I show you these is because if you go on the internet and Google complementary therapies, what are you going to get? Right? An explosion. So I tell people, I don't mind as a doctor if you Google, do not go past page 2 because page 3 is a bunch of foolishness. That's what I'm just saying. Don't go past page 2. And then before you even get to the information, they give you some ads, right? All these ads, they look amazing, you know. They don't give you the price, but they sure look awesome. Well, in complementary therapies, we underutilize these, and in allopathic medicine, we don't show them the respect they deserve. And because we don't talk about them, and because we are not educated about it, and they don't have the randomized clinical control trial, so we can't promise you that it'll work like your therapy, we sometimes poo-poo it. The problem is you guys are going to do it anyway. And because we don't know, that you might end up in a place that's not reputable, that might look reputable. So it's really important, no matter what system that you're in, if you want to advocate, that we should know about these. So we can talk with you about them, talk about the data, so because you often have to pay for this out of your pocket, and you can make a really good decision, right, of what you want to do. Supplements. So at our institution, we happen to have 2 naturopathic doctors, NDs. And what they do is look at the literature behind the supplements that you're taking, because all the supplements can be helpful. Many of them work, but you have to have the right dose. And then if you're going to take these supplements, your oncology team has to know, because as I tell people, whether or not like Big Pharma makes it or grandma's mixing it out back, it's a medication metabolized through your liver, and everything else you're taking is metabolized through your liver, and they can have interactions. So it's not bad to take these, you just want to make sure they're not going to make your treatment ineffective. So that's why your pharmacist needs to know everything you're taking. I love Devil's Claw. I don't know if I would take Devil's Claw, but it's helpful. But I don't know why they named it that. So what are the other people, and I just wanted to make sure that I reiterated what are some of the other specialties that you may have access to, because not everybody has access to palliative care. They don't. So palliative care specialists, pain management, there's cancer pain, people do psychiatrists, cancer rehab, NDs, and integrative medical specialists. So I won't read all these definitions, but if you have the slides, this is the definition of what these are and what they do. Marijuana, cannabis. I give a whole talk on that, but just to let you know, if people are using this, what you want to use is real marijuana. In Georgia, you need to have a card, or if you don't, if you can go in and buy marijuana or THC without a card, that's not what you're getting. You're getting Delta 9 or Delta 11. Those are completely unstable and can possibly harm you. So that's all I'll say about that. But a lot of our patients are using that, and if you have questions, I'm here to answer those for you. All right, and I'll skip over advocacy. I'll skip over the barriers to getting to palliative care, but this is what your oncology teams are really worried about. They don't want to lose you as patients. They don't want you giving up. Many still think of us as only end-of-life care. And then what drives me insane is you have no evidence of disease. That is the most asinine statement I've ever heard. If you have had a cancer or any illness, you have all the evidence of disease even if the disease is gone. So that doesn't mean you need support. So I'll just go ahead and leave you guys with a call to action. You are not your cancer, you are a person treating cancer without treating what the cancer is doing. Not treating what the cancer is doing to you is substandard. Your organizations need to fight just as hard for your living. They need to fight just as hard for your quality of life. Because what's the point of doing all this if you're miserable, right? So you not only want to live, but you want to really live. And that is incredibly important. And then and if anybody tells you, oh, you shouldn't have that because you have no evidence of disease, that's completely ridiculous. So I'll go ahead and stop there, because it'll be time for questions.
Well, we have a few minutes for a couple questions. If anyone has a question, we can answer any questions. Well, I know you're gonna have another session this afternoon. Okay, 2 questions. Okay, let's this lady and then come back to the gentleman. Okay. Could you stand up? I'll make sure we hear you.
There was a slide up there say something about proton and proton.
Oh, yes, so those are like Prilosec.
I take proton.
Oh, yeah, so proton pump inhibitors, those are like the stomach
I
acid.
take pills like proton.
Yeah,
Yes.
yeah, and so they can cause a little bit of dry mouth. So if you need to treat your GERD, but if you notice that you're taking your mouth is drier, then that's probably why. Don't stop taking it, but get like some Xylomelts at night.
Xylomil.
Xylomelt.
Spell.
XYLIMELT. If you put XY and put dry mouth, they'll come up. You can get them from Amazon in a pack. The spray works in the moment. So like if you're out at a restaurant or you're somewhere and you're like, it'll work in the moment, but it doesn't last. So that's why Biotine's great or gum health, but it doesn't last. But the melt coats your mouth and it may not necessarily alter the taste as bad. And then the other thing I have up there, tart cherry, can help restore some of the taste of the food and get that nasty taste you have out of your mouth.
Great, thank you. The gentleman over the back.
Yeah, thank you so much for the presentation. You talked extensively on Sony, and I appreciate it. Mine is a little different. I speak more than I think I should. I do my address this. Sometimes in the afternoon I just do so.
So that hypersomnolence or that fatigue, what I often tell people is, number one, let's take a look at your medications to make sure that we're not giving you something that's perpetuating that. So if you have a pharmacist that works, just let them know. The other thing that happens is there's a lot of dehydration and not eating as much. And it sounds like, a lot of patients will tell me, I feel like I'm eating enough, I feel like I'm drinking enough. But when you have cancer, that thing in your brain that tells you what your calorie count is can dial back. If you had to been in the hospital for extensive periods of time, we starve you for every test, and you don't eat regularly, and that dials back. So once you get used to eating less, then you don't feel hungry, but your body still does. So the other thing that happens is sometimes it may not even have anything to do with the cancer, and we look for sleep apnea and things like that can creep up that you could compensate for before you became ill, but now you're ill, you're no longer able to compensate for those things. And then if nothing else is working, we will use a stimulant then, because as we're not treating fatigue, we're actually treating you're sleeping too much. So the wakefulness medications then are indicated.
Well, again, thank you, Kimberly. Really appreciate it. We do have a token of our appreciation, but we're going to save it because you're doing another session, right? Again, I hope you learned a lot. I certainly did. So let's hear it. If you do have questions beyond this session, don't forget that the LLS table out in the exhibit hall, the patient outreach and community outreach, you can go to those folks there and ask questions, and they can find some resources for you. The other thing I was going to say is everyone, when you came in, got a survey. This is really important for us because every time we plan one of these, we want to base it on what you guys want and need. So please make sure you fill out the session, and then you can do the other sessions this afternoon and turn it in. Okay? So we will be now breaking for lunch. So if you want to